Okay, so hi everybody. My name is Jeehoon Kang, working at Seoul National University, Korea, and this is going to be the how to do it video of the cardio-onc field. And today we have Chris from
Hi.
the National University Hospital of Singapore, and he's going to share us a case, and then we're going to do some discussions. We also have Dr. Sheng and Novi from our editorial board who is participating as discussants. So for the sake of time, Chris, could you start your presentation?
Morning, everyone. We're going to go diving straight into something very practical in terms of cancer surveillance for cancer patients. Cardiac surveillance. So I'm Chris and I'm from Singapore. Now, the first question I think that we want to know is, which patients should we be careful with? And the problem with cardio-oncology is that prior to the guidelines, which were published 2-3 years ago, there were a lot of different consensus papers. So I think to make things easy, I would just keep drawing a reference to the first and only guideline that we have at this point, and that's within the ESC 2022, which you can see the reference below. But really, so if you're familiar with cancer therapies, then there's certain groups of cancer therapies which are more predisposing towards cardiotoxicity. But if you're not familiar with the cancer therapies, we can think about it in terms of the types of cancers. So your breast cancer patients tend to have certain form of toxicities from anthracyclines and your HER2 receptor antibodies or your therapies. Your colon cancer patients have 5-FU, fluorouracil, Xelox, Xeloda. Your blood cancer patients are on various forms of receptor inhibitors, which also affect cardiotoxicity. And I think lastly, the immune checkpoint inhibitors, which are used to treat a variety of cancers, your lung, your kidney, your skin, and various cancers, they also have cardiotoxicity. So again, if you can't remember the different toxicities, then at least some of these cancers should probably make you think harder about thinking what kind of therapies they're on. So, and that's important because it can cause heart failure, myocardial infarctions, hypertension, myocarditis, and these various kind of effects. So the important thing is, how do you then identify the at-risk patient? So it's really about basics first. So you assess the cardiovascular risk factors, you do an examination, and you do a baseline ECG. And this is what I would say you do probably for most of the patients that come to you. For certain patients, you would think about blood tests like a BNP or a troponin. And for certain patients, you may think about a baseline echo as well as subsequent monitoring. And you would then think about using certain risk stratification tools to help guide you in terms of, how at risk this patient is. So again, there are plenty of risk assessment tools, but I think just to standardize, I think I will again go back to the guidelines, and this would be the one that they proposed from the ESC guidelines, which you can find online as well. And they group it according to your different therapies that you can see on the top left-hand corner, anthracyclines, various inhibitors, and it's really just a tick box or a check box. You put the values in and you get different classifications of low, medium, or high risk. And based on that, you go back and you figure out what you need to do subsequently in terms of your monitoring, as well as any treatment required. So how often should you be really monitoring your patient? And that comes up very often. Various therapies have various propositions for the regularity of your monitoring. Anthracyclines have its, as well as your HER receptors here. You classify them on the left according to low, moderate, high risk. And according to your different cycles, you can think about the frequency of your monitoring of blood tests and echocardiograms. Now, this really, I think if you can see there, is class 1, that's green, but the class 2 and the class 2B recommendations are pretty much prevalent in this recommendation as well, because I think the evidence base is still building. But again, this serves as a guideline and not really, I think, the holy grail that we have to follow to. So what is considered an abnormal result? Again, plenty of definitions before this guidelines, but I think it's always good to have a standardized form of guideline so that we can always go back in terms of definitions. So I think the first question in your mind is this patient symptomatic or asymptomatic? And most of the time, your patients will be asymptomatic just because it's a lot more common that they're asymptomatic. If they're symptomatic from heart failure, treat them accordingly. But really, if they're asymptomatic, then I think the question is it severe? Is it moderate or is it mild? And it uses the different criteria of your LV-EF reduction, as well as some form of strain, as well as cardiac biomarkers. So the idea is that based on the severity of the cardiac dysfunction, you would then think about different management strategies for your patient. So this is really the baseline that we think about in terms of approaching a patient. And I'll just go straight into a case so that to think about how we can use this in practical day-to-day kind of use. And this is a case from one of my colleagues back in my hospital. So this is a pretty standard case. You get a 48-year-old lady who comes to see you in the clinic. Maybe not so common in this case because 48-year-old ladies are usually a lot healthier, but this 48-year-old lady wasn't the healthiest. So she had hypertension, diabetes, and high cholesterol. And you can see that all three of them are really poorly controlled. She's on a combination of medications that you see here, some diabetics, some cholesterol medicine, and some antihypertensives. So she comes to you because she's been diagnosed with right breast cancer. She's HER positive and she's estrogen as well as the progesterone receptor positive. So her plan from the oncologist, so that's not something that you need to plan for, but she's planned for docetaxel as well as some HER2 therapies, as well as subsequently she's planned for some anthracyclines, as well as in the form of doxorubicin and cyclophosphamide. So you think what you need to do in this case. So recognizing that this patient has breast cancer, you start to think that, okay, you look at her therapies and you realize that she's on anthracyclines as well as anti-HER receptor kind of therapy. So she's at risk now. You go and examine her as you would, and you look at her cardiovascular risk factors, and you realize that they're all poorly controlled in this case. Presume that the ECG is normal. You run through your risk score that we were showing before with this, which is the HFA-ICOS kind of score, and she comes up to you as medium risk, predominantly from her poorly controlled cardiovascular risk factors. So the next question is, what do you do having this patient who is now termed as medium risk? So you can think of it as providing closer monitoring, managing the risk factors, and if you are not a cardiologist, this is when you may think that you might want to refer the patient on to cardiology for further review. And what do you do in terms of the monitoring then? So we have this patient who's classified as moderate risk, and you will see that in moderate risk, that will put you in the top half of this graph here. You would see that you will probably be recommended to do a baseline ECG, and it will be recommended to do an echo every 3 months throughout her therapy. The blood test is a bit plus minus, it's a class 2B, but you'll see that for every 3 months, it's sort of recommended for you to do some form of cardiac monitoring via an echo. So that's what happens. But realistically, these patients don't come to you this way. So what happened with this patient is the same patient, but so she actually in our center, because I think it's interesting that different centers have different maturity in terms of the whole awareness of cardio-oncology. So in our center, what has happened is that some of our oncologists have some basic awareness of cardio-oncology. And what they've done is that they've actually given the patient the treatment of the 4 cycles of the HER2 therapy. And what happened and subsequently when they gave her the anthracyclines, in the first 2 cycles of anthracyclines, it was uneventful. Now, in the 3rd cycle, for whatever reason, the oncologists who have a bit of more awareness, they did an ECG and it showed some T-wave inversions. So they went on to do a troponin, which was mildly abnormal, 50s to 80s, and the normal range being less than 26. And importantly, this patient was asymptomatic. So in this case, that's the reason why the patient got referred to us, because there's some ECG abnormalities, a raised troponin, and they weren't quite sure what to do from here. So this is what happened for the patient. So at baseline, her EF was normal, and she had a strain which was minus 17. You can think of it as strain being the more negative, the more normal it is. You would probably go for at least minus 20. Some people go for a gray zone of somewhere even lower. But this strain is a little bit abnormal in this case. 4 cycles of the therapy from before, and 3 months later, EF now drops to 52%, and the strain has dropped to 14%, minus 14. And this is still prior to seeing us in cardiology. So the oncologist was going ahead still because the EF to them was all right. They gave 2 cycles of anthracyclines. And what happened was that, as you saw before, there were T-wave inversions, troponin was elevated, and the patient was referred to us for further evaluation. So the question is at this point, what do we do, be it if you're a cardiologist or if you're a cardio-oncologist? So this was the echo that was done prior to referral to us. And 5 months later from her therapy, her EF has now dropped to 50% and a longitudinal strain of minus 14%. So nothing terrible if you're not a cardio-oncologist, but I think the overall trend is that it has been decreasing a little. So what do we do here? I think the bare minimum was that the summary of this patient firstly is that she's asymptomatic, but now her EF has dropped from 58% to 50%, which is low normal. Her strain has dropped from minus 17 to minus 14%, and that gives you an absolute drop of minus 3%, But if you're talking about a relative drop, that's about a 16 to 17% drop from minus 17.8 to minus 14.8. And she comes to you with an abnormal troponin. So I guess the question is, what do you do at this point? So if we go back to our definition, this patient now falls under the mild kind of category. So her EF is normal. She's got a relative decline of your GOS by more than 15%, which we calculated was about 16%. And she has some abnormal cardiac biomarkers. So if where I was going to put her on this table, she would fall under the mild cancer therapy-related cardiac dysfunction group. And it's these kind of patients that, again, you're not quite sure what to do. Do I need to act on it? Do I not need to act on it? And I think that's where it comes a little bit, soft in terms of what we should do. But if we're going to look at some guidelines for protocols to guide you through, what you would see here is that if we look at our patient, so now on the top dichotomy there, whether she's symptomatic or she's asymptomatic, we have classified her to be asymptomatic. Now, in the level below that, we've classified her to be mild in terms of the abnormality that we've done going through the algorithm before. So if she's mild, it brings you down further to the right-hand side where it says continue with anthracyclines and your cardiovascular monitoring. And if you go further down in terms of the cardiovascular strategy in the third strata of this picture here, we showed that the longitudinal strain had actually decreased by more than 15%, and there was actually an increase in your troponin as well. And therefore, that puts you right at the bottom in terms of where she is there. And you would consider, ACE, ARB, or beta blocker as a class 2A indication. So that's where we're at for her. So what did we do for this lady? I think the first thing was because, although she's young, because she had multiple cardiovascular risk factors, we just wanted to evaluate for any ischemic heart disease. So we did a CT coronary angiogram, which I think expectedly showed minor coronary artery disease for medical therapy. So having excluded ischemia from this whole equation here, what we did was really aggressive optimization of our cardiovascular risk factors. So what we did in that sense was that we changed the simvastatin to atorvastatin because there is also some evidence for atorvastatin in terms of your anthracycline kind of cardiotoxicity. We added a beta blocker. We added a SGLT2 inhibitor, again, plus minus, but some possible growing evidence in terms of observational studies. And we further increased her lisinopril dose to try and optimize her cardiovascular risk factors. So with this, I think importantly, as a cardiologist, I need to stress this, that your role is not to stop cancer therapy. So your main aim is really to try and support the patients to go through their cancer treatment such that to allow them to complete their cancer therapy without any interruption, because with interruptions, it tends to cause, decreased efficacies in terms of the cancer therapies. So subsequently, she completed her therapy and she went through a right mastectomy. And I think the important thing at the end of all this, you will see that her EF has actually improved and her GOS has improved as well. Whether is this due to the cessation of therapy, whether is this due to the increased intensification of the medications, I think that's a separate discussion to have. So really, I think, and the important thing is that if you actually looked at the start here, there was actually probably some indication that there was actually the GOS dropping by quite a significant portion right at the start, which may have prompted early referral to cardiology if, let's say, people were, more aggressive about this whole thing. But nevertheless, conclusions. So I think the important thing is for anyone who's encountering patients with cancer and in terms of cardiotoxicity is to first be aware of which therapies are commonly cardiotoxic, and I think how to at least approach these patients in terms of risk stratification at baseline. The next thing is to recognize an abnormal result, and I think when and how you should think about initiating some form of medications for cardioprotection. And the last thing, again, is I think the main thing as a cardiologist is that while people are afraid of all these things, and sometimes it goes the other way, they get a bit more afraid of the heart rather than the cancer itself, and I mean the physicians themselves. So our role really in cardiology is not to stop the cancer therapy. And I think the main aim is really to try and keep the patients safely on it and support them through this journey. And I think that's the end of the case. And I think, always glad to discuss further because there's a lot of variations in terms of how we practice cardio-oncology within the different countries.
Yes, thank you, Chris, for this very wonderful case. In my opinion, I think that these kinds of patients are seen very oftenly in the clinic. Probably the ones who come to our clinic are just a very small portion of the patients who experience these kinds of events. So just to jump into the questions, I could see that this patient had very not well-controlled hypertension, dyslipidemia, and diabetes. Then who should be managing these kinds of risk factors? These are traditional risk factors for cardiology, but they are also risk factors for overall event. So it's not the cardiologist who should do it. It can be done by endocrinologist or the oncologist even. So who should be managing these kinds of?
No, I think that's a great practical question because I think it really depends on how set up your countries are. So unfortunately, in Singapore, while we're trying to get the primary care better, I will tell you that our primary care is still probably has rooms to improve compared to probably the other countries. So unfortunately, I will tell you that oncologists, just like most oncologists in different countries, probably don't have the time to look through the cardiovascular risk factors. They've got a lot on their plate. They've got to talk about treatment. And unfortunately, most of them won't actually control the cardiovascular risk factors. So I think in an ideal world, it would either be someone in the primary care, but I'll tell you that realistically, and I think research has shown is that a lot of patients with cancer actually have poorly controlled cardiovascular risk factors. And I think it's just because there's probably a lack of ownership in this case. And I hope that, maybe in other countries will be a lot better than what I see here.
Okay. The second question is, as this patient experienced, the EF was low normal until she was referred to cardio-oncology. But again, it was still at least normal. Well, low normal, but normal. So then, a lot of these patients may not have been even referred to cardio-oncology because the EF is normal, and that's one of the most uh, definite parameters that non-cardiologists look at when we see the cardiac function. So how do these patients get triggered to be referred to cardio-onc?
Hmm. So again, it depends on how mature your system is, because I can tell you that ultimately it depends on whether the oncologist is aware about the need to refer the patients on. So with at least in our center, because I think we've been collaborating quite a bit with oncologists, there are a few oncologists who are a little bit more aware. So I think they are aware that the moment the EF starts dropping, they actually start thinking about a referral. Different oncologists have different levels of worry, which you can imagine. Some will tend to refer a lot earlier. Some will tend to refer a lot later. Some don't refer at all. And I think, unfortunately, a lot of this is about awareness. And I think while we are creating awareness within cardiology, I think ultimately the awareness has to be created within oncology as well, because they are the primary source of referrals. And I think that's where, it gets triggered in that sense. So I think that the real question is, whether there's enough awareness and whether we can actually get the message out to an oncologist a little bit better.
Yeah, so the field of cardio-oncology itself is not that much familiar compared to like intervention and echo. So we have ourselves have to be aware of this field and what we should monitor. So any questions from the other panels?
Yeah. Thank you, Chris. That's a fascinating case, and thank you for walking through the surveillance guideline as well as the algorithm when to initiate heart failure therapy and also discuss discontinuation of the cancer therapy and all that. I have a question regarding the guideline that you walked through, and then you mentioned a lot of testing. How much of the guidelines do you follow in practice, including troponin, echo, especially with GLS, with the strain? How commonly is that done for the cardio-onc patients? Do you try to do it on every patient? Should oncologists just, when they get an echo, be doing the strain every time? And I ask this question with the caveat that we know that the strain on echo is not available at every center in Asia. So, yeah, just want to hear your thoughts on that.
Yeah, no, I think it's great to hear what everyone does because I'll tell you how it's matured. So when we first started, we created a unwanted, in a way, demand for echoes. So in a way, you're flooding your system with echoes. And I think just with most centers, you end up having a ridiculous waiting time for your echoes. So some of these echoes actually would end up getting done, only being done about 6 months later from when you would request them, compared to whenever the guidelines would specify. I think that's a very real problem. And I think different places will probably have different ways to get around it. So what we've done to get around it is that now we really just offer a very focused echo for the cancer patients. So the only thing is that they come in, they get an echo for the strain, as well as they just get an EF. We don't look at any other view. So it's really just a 4-view focus kind of thing. And that tries to help with the turnover for these patients. So that's something that we do it for the cancer patients, so they get it a lot more frequently. Now, I guess if we don't have strain in certain countries, then I think one option will be to do 3D echoes if you have. And I think if we really don't have that, then it's really just back to basics about just measuring your 2D EF. And I think while strain has been shown to have some benefit, I think it's still debatable in terms of the heart outcomes at the end of the day. So I think it's a luxury, but I won't think it's something that is a compulsory need to have. And I'll be honest with you that I think in terms of monitoring, it's difficult. 3 monthly echo is not simple for a patient if they have to pay it out of their pocket, if they're not living in the center. And I think realistically, most of the time, you probably have to come to some form of compromise. I mean, like Novi would probably know, in Indonesia, I'm sure it's not feasible to do echoes every 3 months. So you have to come to some form of compromise. And I think there are studies that are trying to look at reducing this monitoring, but we can always talk about that if we're interested.
Thank you for that. Yeah, it's very fascinating that to hear that you developed this protocol at your center to target the protocol that's dictated by the Cardio-Oncology Society in focusing on the EF and the strain. I have an additional question regarding the medications. You mentioned in the guidelines that they recommend ARB or beta blocker when they have these the cardiac dysfunction related to cancer therapy. In a patient otherwise without risk factors, young, and with otherwise, except for their cancer, healthy, asymptomatic, what do you usually go for first?
Yeah, so breast cancer patients are probably the biggest proportion of patients that are going to come to you. And hopefully most of them are young. I mean, not hopefully, but a good proportion of them are youngish. And with young ladies, they're going to be relatively healthy most of the time. So, here you are, they are on cancer therapy, and here you are trying to add more medications to them. And I'll be honest with you that the evidence for primary prophylaxis with beta blockers, ACE, ARBs, whatever you want, is not the strongest at this point. So I think a lot of it is sort of a bargaining kind of thing. And what I would do is that, again, I think we're not sure about the duration of medications, which we may allude to later. But I think the way I would do it is that if I were to start any of them on medications, the way I would propose to them is that I would tell them that it's maybe 1 medicine, sometimes 2 if they're comfortable. But usually they're only keen for about 1 in my practice. And usually I tell them that it's the lowest dose. And importantly, at the end of the day, I try to tell them that this is only temporary. So I try to tell them that I'm going to do this only in the time of their cancer therapy with a view of stopping them later. So that helps to get buy-in because really people don't really want medications. And again, whether there's evidence about the duration of the medications, again, we can talk about that later. But that's how I try to get buy-in. Minimal medications with hopefully the promise to them that it's a short-term thing during their cancer therapy.
Yeah, so Novi, you're an expert in heart failure and the cardio-onc field. So I suppose that you have some questions that are much more sophisticated than mine. So do you have any comments?
First of all, thank you so much, Dr. Kang and Chris for inviting me. And Chris, thanks so much for the very nice case. It really the thing that as Jeehoon mentioned, the type of patient that we saw almost like all the time in our clinic. And this type of mild, moderate type of patients. Because we know if it's the patient is have a full-blown heart failure, we know what we are going to do. But it's always the question that we ask if this patient just having mild things, moderate thing, or what are we gonna do? So it's very important. So I'll just maybe ask question regarding your last statement about it. Maybe discontinuing these medications. Based on so now after we started all of these medications, ACE, BB, sometimes SGLT2 inhibitors, when we see the CTRCD. So always the big question is, do we keep this forever or can we stop them once LVEF is recovers?
Yeah. I think if they have full-blown cardiotoxicity, like with symptomatic heart failure, then I would treat them like a heart failure patient. And I would probably be a little bit more cautious about stopping them. But I think for these asymptomatic mild kind of patients, I tend to try and remove it. There's no guidelines or no evidence at this point, but there are people in Canada as well as US trying to investigate if you could safely stop these medications. I think in Australia as well. But I think the main thing is that at least with the lack of evidence at this point, my own anecdotal kind of practice is that I tend to stop them if they're asymptomatic and mild upon completion of their therapy. And I would probably monitor them once or twice with a repeat echo after that. And if it's okay, I tend to just stop it. And my anecdotal experience so far is that most of these patients are completely fine without their medications as well. So which brings the question, are we over-treating them? I don't know. So hopefully, we get some evidence in future.
Yes, thank you so much. So we know that the guidelines tell us to monitor the patient. I mean, they give like a fixed timetable to do echo and stuffs, especially with patients with heterotherapy and anthracyclines. So do you know whether when we can actually de-escalate this surveillance, especially in carefully selected like low-risk patients? And I mean, in your practice, do you see a role of like this individualized reduced frequency monitoring?
Yeah, no, I think that'd be great if you can individualize it, because I really feel 3 months for all these patients is a big toll on them. You know, these cancer patients come in for cancer therapies, they have frequent appointments, frequent blood tests, and now you're piling on regular echoes on them. I personally feel that we can reduce it. Again, I know there are people in in the US, I think in the New York Center as well as Canada in Toronto, that are trying to look at a reduced kind of frequency protocol monitoring and its safety. I would expect the results to show that it's safe to do a less frequent kind of monitoring. But yes, in my practice, if there's some reluctance on the patients, you know, if they're elderly and whatnot, I tend not to enforce this on them, because I think it is ultimately a very practical kind of decision at the end of the day.
Yeah, and I think I've read some study also published in JACC Heart Failure. I think they were recently done by I forgot the center, but basically in that study said that we can, in carefully selected low risk type of patient, we can, it's kind of safe to reduce the monitoring. Of course, in carefully selected patients. Well, I think that's all for me.
Okay, well, thank you, Chris, for your wonderful presentation and your explanation and sharing your perspectives in this field. Qicong and Novi, it's wonderful to have you guys to have these wonderful questions. And for the audience, I think that this video will help starting this field in cardio-oncology. If the audience have anything that you want to further investigate in this field, you can contact us anytime. If you have personal contacts with Chris, that's okay probably with you, Chris? Okay,
Yeah,
so
sure.
thank you everybody for joining this, and I hope that we can see each other in person in the near future. Thank you. Bye.
Thank
Thank you
you.
so much.